Systemic manifestations of COPD continues. Circulating leptin promotes systemic inflammation in COPD. Telomeres get progressively shorter as cells divide, and this is accelerated with oxidative stress. COPD is a disease of accelerated aging of both lung and other systems of the body. Consequences of systemic inflammation are skeletal muscle wasting, cachexia, lung cancer, pulmonary hypertension, ischemic heart disease due to endothelial dysfunction, congestive cardiac failure, osteoporosis, normocytic anemia, diabetes mellitus and metabolic syndrome, obstructive sleep apnea syndrome, depression, COPD and heart. Three times increased risk of heart disease in case of COPD population than in general population. According to TORCH study, 27% increased mortality in COPD patients due to heart disease. And poor lung function is a risk factor for cardiovascular diseases, atrial fibrillation, arrhythmias, diastolic dysfunctions. In heart failure, electrolyte derangements seem to increase bronchial hyperresponsiveness. Vertebral fractures present in 50% of steroid naive males with COPD. Osteoporosis may be related to raised TNF alpha and interleukin 1, which stimulate the differentiation of macrophages into osteoclasts via mesenchymal cells releasing receptor activator of nuclear factor K beta ligand. These osteoclasts cause increased osteoporosis. The proposed mechanisms for weight loss in COPD are raised interleukin 6, decreased food intake, hypoxia, growth hormone resistance, decreased IGF 1, and decreased testosterone. According to TORCH study, that is Towards a Revolution in COPD Health Survival Study Protocol, only long-term oxygen therapy has been shown to increase survival in COPD patients. And the prevalence of comorbidities in COPD are arthritis 47%, cardiovascular diseases 20%, hypertension 20, diabetes 2.9%, dyslipidemia 11%, psychiatric problems, GI problems 39%, cancer 4%, osteoporosis 32%. The presence of inflammation and markers of inflammation predict the development of diabetes and metabolic syndrome.